and welcome to today's WHAMinar, which is titled Advocacy in Action. Now, my name is Dr. Goody Singh, and I'm going to be your host today. Today's session goes on until 2:30, and from now and until then, we're going to be joined by three wonderful guests who are going to help us to think more deeply about the question of what does it mean to be an advocate in the 21st century. Now, in some ways, sadly, this question has never been more relevant because unless you've been sleeping under a rock, you probably know that things are not in great shape at the moment. It's April 2024, and in the UK, public sector workers are still on the picket line. The cost of living crisis still burns on, and our leaders are still in disarray. And 4 million children are still living in poverty in what is the fifth richest country in the world. Meanwhile, in the rest of the world, 15,000 Palestinian children have been killed in Gaza in just 180 days. And the climate crisis just burns on in the background, which means that there's a lot of work to do. Now, this event has been brought to you by WHAM. And for those of you who don't know what WHAM is the Wellbeing and Health Action Movement, which is a social incubator or a digital platform for the peer-to-peer sharing of the knowledge, tools, and community to inform, empower, and unite clinicians who wish to address the social determinants of health and health inequality in their clinical practice. Now, we exist because we believe that all clinicians, from the bottom to the very top, and of all stripes, can and ought to be advocates for and with our patients. But what does that look like in practice? So we have three very special guests who are going to give us their take on what that means for you now. And I have great pleasure in introducing you to first Joanna Martin, a clinical nurse specialist for pediatric respiratory illness and infectious diseases at UCLH. She also works with asylum seekers and refugees as part of her work. And we're really delighted, Joanna, to have you to give us the nursing perspective on advocacy today. We also have Tony Waterston, who is a retired consultant paediatrician and who used to work in the community in Newcastle. Now, as well as his clinical work, Tony has also worked for the RCPCH. He's developed a diploma in Palestinian child health. He was an editor on the Journal of Tropical Pediatrics and is on the executive committee of the International Society for Social Pediatrics, or ISOP. And again, we're really lucky to have you, Tony, to bring the doctor's perspective to today's discussion. And last, but most importantly, we have Grace Kariuki joining us. Now, Grace is a full-time mum of two children, and she has been seeking asylum to the UK. We'll have an update on her story shortly, but she has a son, Adrian, who has cerebral palsy and complex medical needs. And Grace has been advocating for Adrian's needs in the health system, education system, and social care system on a daily basis. Now, Grace is actually an old friend of WHAM, and it's lovely to have you back, Grace, giving the lived experience of advocacy for us today. So, the RCPCH states that paediatricians are committed to a policy of advocacy for a healthy lifestyle in children and young people and for the protection of their rights. And when most paediatricians think of advocacy, they see it as this very lofty venture that must be the preserve of the great and the good, meaning that they leave it to the college and they think maybe that they've been left off the hook. What I hope you will see today in each of our three special guests is that there is no single definition, shape, or size for what it means to be an advocate. Now, Grace, I'm actually going to start with you because I think in a way your story helps to really bring this and solidify this more clearly than anything else. And I really want to stress that advocacy is not for patients, but by and with patients. So, Grace, first of all, can I just get you to start by telling the audience just a little bit about you and your family?
Okay, I'm delighted to be part of this meeting today. My name is Grace Kariuki, and I'm a mother of two boys. One has cerebral palsy, and we are just new in the country. We are just now 2 years in the country. Just the other day, we were given asylum. We were asylum seeker, and we were given leave to remain. It has been a struggle being asylum seeker. It has been a struggle for you to access a facility and services. So it has been tough for me to do all those things, but without giving up and not being relentless, I have been really trying to advocate for my son to achieve the best. And with that, he has been in school, and with that, he has really attained a lot of attention and a lot of support from the medical team, social services, and it has really helped for me not to give up. It has really helped me a lot. And I can tell people never to give up on their children, no matter how situation hard it is. Never give up, because even if you try today, tomorrow you'll achieve what you want for your child. So it's good never to give up, no matter how hard the situation is, because in asylum seeker, everything you are told you are not qualified, because it's true, you are not under the system of the country. You are new, and before you get that system, you have to struggle for you to achieve that. So it's not good to give up on our kids, no matter how hard it is. It's good always to fight for them and never lose hope. Yeah.
Oh, Grace, we couldn't have had a more hopeful start to this webinar, and I'm so delighted that you've managed to get your leave to remain. And maybe you could also update us. I mean, you said about the housing. What's really interesting about your story, Grace, is that you've had to interface with literally every aspect of our society, right? So the health service, obviously, and Hannah is actually had been your clinician previously, but there's also the school sector, as you described. There's social care and housing, and you've needed financial support. Tell us a little bit about what it's like to try and advocate, when English may not be your first language, but also you are new to the country and you don't know how the system works. What does it mean to advocate for yourself in that kind of setting?
You have to have good relationship with all those under the services. Like Hannah, she has been so supportive to me, and the secret behind it is having that good relationship with her, because if I had not had that good relationship, I could not have achieved what I have achieved today. So for me to advocate for my sons, I have to have that good relationship. In terms of housing, it has been really a struggle, because while we were being taken with my son Adrian, it was not good. It was not a suitable house for his needs. It was very small house, and they wanted us to go there, but telling them, explaining my situation and explaining what I'm going through to doctors like Hannah, they really supported me by writing letters to the Home Office to explain the needs of my child, that house is not suitable for my son. And it really helped me a lot, because they did not push us to go there. So once they got that letters from doctors, from social services, they did not push us to go there, because they supported us with writing and emails, which matters a lot. So after now we were given leave to remain, the council took us now in, and through the help of those letters from our doctors, from pediatric, from physiotherapists, it really helped us, and we were given a spacious house which caters for Adrian's health. It really caters for his health, and it has a garden which is appropriate for his needs. So by having that good relationship, it matters a lot for you to benefit, for you to have that, what your kids needs is starting to have a good, and never give up. Even if today you're told it seems you're not gonna make it, never lose heart. No, never give up. Always be there. Always try to knock the door and say, please, can you hear my story? Can you hear me? It's not easy, but if you can listen to me and understand what I'm going through, you'll see what I'm going through, and you'll see that I really need your help.
And so what's really interesting about what you're saying there, Grace, is that the role of the clinician, whether it's a doctor or a nurse or anyone who's in the team that could be seeing you, and let's be honest, with someone like Adrian, you must have such a big team of clinicians who are taking care of him. Any one of those clinicians actually has the power to be able to help you to make the case for better living standards in your life. And I guess we can come on to what Tony and Joanna how they would respond to this and what they think about it. But just to all of the clinicians who are listening to this, sometimes it feels like we've been given this additional task. Oh, we have to write a housing letter, or we have to do this additional bit of admin. And I know that on top of everything else, it probably feels like one extra thing. It's onerous. It's also not necessarily our skill sets. It's not what we're all trained to do necessarily. However, just now that you've heard it from Grace's mouth, there's probably nothing more important than what you're doing in that day than writing that housing letter and adding your kind of weight behind someone else's case for things that they are entitled to, but they're not easily kind of won in our current climate. Grace, you haven't just, but what again, you're so what I don't understand about you actually is that you have had one of the toughest battles, and yet you're still so positive, you're still so optimistic, and you should be a motivational coach or something because I'm listening to you and I'm thinking, yes, never give up. But what I'm curious about is how do you keep going under all of this strain? Because I'm sure that raising your kids in this country, in this climate, when you haven't had secure housing, you haven't had secure leave to remain, your residency status, all of that must be really hard to deal with. And yet, how do you maintain that energy and that positivity?
Um, what really keep me going is when I look at my son Eden, who has special needs. I see he has a bright future, and that keep me going, push me to do more, to do what I was not. I never thought I could do for him, because he being disabled, it doesn't mean that he can't make it in life. He has a lot to achieve, so that always give me that spirit, that determination to push and push until I see he can do something by himself. He can be independent. He can, at least he has achieved something, so that in future he will not ask me, "Mommy, why didn't you do something to at least to help me? Mommy, why didn't I don't want to live with that brave. Why did I not assist my son?" So that really gave me strength to move on and to push. Yeah.
Yeah, well, it's amazing. And what, again, is amazing about you, Grace, is that not only have you done it for yourself, you are helping other families to advocate for themselves. And I just wondered if you could now kind of switch focus a little bit and tell us about this work of helping other families to advocate for themselves, and the parent networks you're involved in.
Yeah. Having a special need child, when you see another parent struggling and she doesn't know where to start, it really touches someone's heart, because it is not something for you to rejoice when you see someone else suffering. So for me, when I see most of the immigrant people doesn't know about digital, doesn't know the system, don't know where to start. And for me, it could really touch my heart, knowing for me, I did it for my son. Why can't I help this person? Why can't I help the parent for her child to be in school? So I could take that initiative to assist, because I know the pain of having the child in the house and you don't know where to start. That child need medication, that child need to go to school, and you don't know where to start. So I could take in the initiative to assist by starting by writing emails to the council to assist in EHCP, by requesting for progress. That really helps them so much, because when you ask for progress, the council could see now is our time to assist this parent, because she's now like every time she's checking what is happening, what is the progress. So I tried to help where I can, because it is not good for a child being told that your child is going to school and you don't know the process, you don't know anything, where to start. And English, for them, they don't know English. You have to be patient. You have to be patient with them, because if you give up, they will not get that help. So I could sit down with them, tell them you have to do this and this, provide this and this, so that at least you can get EHCP for a child and for them to be in school. And after doing that, their children they are in school. After assisting them, they are in school. And also we applied for transport. I assist them to apply for transport, and they were given the transport just by listening to them and give them shoulder to lean on. Everything was perfect for them.
Wow, again, just so inspirational. And you kind of drawing on your own experience and having the empathy to reach out to others. Again, given your constrained circumstances, it's really, really so inspirational. And yeah, just amazing. And I just want to just say that before we move any further. But I know that there will be clinicians on this call who will be wondering, Grace, because they've got this opportunity to talk to you. What are your top tips to us as clinicians, in terms of how we can be helping other people like you? What could we be doing, and that you think we should probably have top of our mind when we see people like you in clinic?
when you see people like us in clinic, always be there to ask, is everything okay? Because most of us can't open up, you know, because you are carrying a lot of things in your head. You have a lot of things that are going on. You are asylum seeker. You are being pushed, do this, write this, and you don't even know where to start. I think it's best, it's good for you to ask, is everything okay? So that that person can have that heart to open up. So that even she can cry, telling, and no, I'm not okay. I'm being told to do this, and I don't know where to start. With that, now you can guide her, kindly do this and this. You can read her or him to try this and this. Because for me, if I could not open up to someone like Hannah, I could not be here today. I did open up what I was going through, and now she told, I will assist you by doing this. I'll let a letter for you to support this. So it's good to ask, is everything okay? And with that, now you're following up. How have you, is after now that person opening up, it's good for you to follow up. How are things? How are things going on? Have anyone get back to you? At least now should be more and more open. No, they haven't done this, they haven't, at least now they'll be free for you to talk, and they'll be push, and things will work out for them. Yeah.
That's a fantastic tip, I think, for all clinicians. And I'll just say, thank you, Grace, for speaking to us about this. I hope you can hang on, because I think we'll have some more questions from people probably towards the end of this conversation. But just before we move on to our next guest, I just want to say that as part of what we offer in WHAM, we have a series of tools and questionnaires that can help raise some of these questions in clinic, because we know that this is hard for clinicians to do if they haven't done it before. So if you feel like you're interested and you would like to, Helen, maybe you can pop the WHAM website address in the chat box so that people can have a look. But one of the pieces of work that we have done actually looked at, do patients want to be asked these kinds of questions like Grace is alluding to? And the fact is, patients are desperate for you to open the door to be able to talk about this stuff, because it is just the way it is, and the way that the power dynamics work in clinic. We have to own that responsibility and allow that to be a safe space to talk about this stuff. And so we've got some work on our website that might help you to think about how you want to do it in your particular setting. But Grace, I just want to say thank you for such a fantastic opening to today's WHAMinar, and we will come back to you with some more questions in a bit. But I'm going to move on to Joanna, who is, as I said, a clinical nurse specialist at ECLH. Now, Joanna, when we spoke a few weeks ago, you said something to me that really struck me, and I quoted it, I wrote it down, and you said, I'm a natural doer, and I'm not someone to reform policy or to campaign. Now, tell us a bit more about your work and then what you meant when you said that statement.
Hi everyone. Before we say that, I just wanted to echo what Goody said to you, Grace, that in my role we encounter a lot of the challenge of the asylum system and a lot of people who've been beaten down by that. And I get beaten down by it sometimes too. And so I just wanted to add to say that you're really inspiring how you've just fought to overcome that and not lost hope and kept your positivity. And I know Goody said it already, but I just wanted to say the same thing because it is really inspiring. And yeah, well done.
Yeah, it can never be said enough. So don't worry, Joanna, that's cool. But you can't get out of the question. So.
So yeah, I'm a specialist nurse, and my job is two specialities, which is unusual, but it's respiratory illness and also infectious diseases, and I'm in paediatrics. So the reason that I said that, Goody, that I'm a doer is I think maybe it's more of a nursing skill set, is that you crack on with a lot of jobs, and I think often those jobs involve advocacy, and we can talk about that, but I often feel like my brain isn't big enough to think in a big way and solve problems which are massive actually, and at government level that's often what we're contending with, even in the asylum system. These are huge things. And yeah, so basically I just feel like my skill set's much more to crack on. I'm motivated by the individual patient. Yeah,
no, and I wasn't trying to skew you with that, because actually I think that statement reflects actually what loads of us think. In a way, when you said it to me, I was like, that's what I think. That's what all of us in WHAM have thought at some point or another, which is that I just need to get on with my job, right? Like, what relation has all of this got to do with me? And I just thought it was really nice what you said, because the truth is that your brain is obviously big enough to deal with this stuff, but more to the point that your career demonstrates actually how you are taking like action on all this stuff. And that's why it was really interesting. That's one of the first things you said to me in that conversation. And yet when we started talking, I was like, but you are doing it. And we can talk about that now, because actually you just said it now. You're a nurse and you're in this system, which sadly, even in 2024, is incredibly hierarchical. And doctors are still, for some reason, at the top of this hierarchy. And then, are somehow seen to be like leaders in the medical systems. I wondered whether you could talk a little bit about how you as a nurse felt or have felt empowered to be able to make changes to systems, especially when what we're talking about is trying to make things more equitable for your patients. Have you felt empowered to do that? And if so, what do you think has made you feel that you could take action?
Good question. I definitely feel empowered. I think that in the teams that I work in, we have a really good relationship between the nurses and doctors, and I feel listened to, which is amazing. But also feel free to say, like, when I don't know. Yeah, so I think I think I might have said this to you before, Giddy. I think I'm in a really unique situation because I have an amazing team, which I'm sure lots of us would have, but I know it's not always the case. And it's such a game changer if you all know that you can be honest with each other, and hash out problems and feel listened to. And I feel so respected in my role, which is amazing. And that's a testament to the amazing doctors and nurses that I work with. Yeah, and I think also it's actually been a journey. So I've been in a specialist nursing post for a year, and it's hard to figure out, I think, what's expected of you in a specialist nursing role. And it's hard for me when people look at me and think, oh, she's the specialist. And I'm like, really? I don't even know. But I think it's really valuable to learn what the different people bring to a team. And I have to remind myself that it's not my responsibility to make prescribing decisions or medical plan decisions, because I haven't trained to be a doctor. What I have trained to do is be a nurse. And I think I've learned that is a really valuable contribution to the team in its own way. And I bring something as a nurse that a doctor doesn't bring, for example. And so learning to own that and have confidence in that, I guess, in your contribution to the multidisciplinary team. Yeah, does that answer your question?
Of course, yeah, no, fantastic. And 100% that, nurses bring way more and something different, as you said, to what doctors can bring to the table. I feel like the takeaway from what you're saying is that advocacy is a team sport, right? It's not something that you just do on your own. There is no single hero. And I think the problem with the way that the advocacy is framed in medicine, or can be sometimes framed, is that there is like one particular spokesperson, often the president of whichever college you happen to belong to, who does the advocacy for you. But that's not how it works, right? That's not the reality of it. And so knowing that you can actually distribute that responsibility through your team is actually really freeing, because I mean, it's not all on you. And it means that you can bring your particular kind of skill to the table and kind of excel where you feel strong, right? Where other people can pick up the slack elsewhere. And in WHAM, for instance, we really try and harness that idea that whatever skill or tools you have to hand, you use them for this idea of trying to tackle health inequalities, and that includes things like QI. And QI is something that I know you've done a lot of, Joanna, or you've kind of been involved in that kind of service change stuff. I wondered whether you could tell us a bit about the work you've been doing with on refugee health, and how you kind of changed some of the services there, and what you've learned as a result of that.
Yeah, there's lots to talk about in that regard, and I actually have to give credit to Ali here, who's on the call, because she works within, well, I work with her in some form. We can say more about that if it's interesting.
Yeah,
in my infectious diseases role, we have a lot of asylum seekers as part of our caseload, and we do infectious diseases screening for them. And I guess the problem is that it's so hard for them to access and engage with healthcare, which Grace already alluded to. So some of the things that I think we've learned that they find hard is just navigating the NHS full stop. It's a system that doesn't make sense. They don't speak English. We send out appointment letters written in English and then wonder why they don't come to their appointments. They've got a lot else going on in their heads. Grace, I'm sure you could relate to just having so much to think about in terms of the asylum process, like where are you going to live? Am I even going to be allowed to stay? And so when asylum seekers, people seeking asylum, are consumed with that, it's harder for them to prioritise their health, really, I think is what we have been learning in our services. So that results in them often not coming to appointments, often not engaging in care in a way that we expect them to or want them to. So some of the things that we've done, most recently, we've actually recruited a volunteer to our service who amazingly is someone with lived experience of the asylum system, which is bringing something really special. So she's joining us in our infectious diseases clinics and helping the patients, who a lot of them are unaccompanied young men. She's helping them get around the hospital. So we tell them that they have to take a medicine and they go to pharmacy, but she helps them get to pharmacy, which is actually really overwhelming, or helps them get to X-ray if they need an X-ray. And she's also started doing some appointment call reminders the week before their appointment, letting them know where and when to come. And that already we're seeing an impact that more patients are coming. So yeah, that's been a really valuable piece of work, and I'm excited to see, as we start to audit that going forward, the impact. And hopefully, I mean, already aren't we, Ali, excited about how we could implement that in other services that we're running for people seeking asylum. And then I guess another big part of it is, I think in my role as an infectious diseases specialist nurse, I'm released by my team to take time to do some of the advocacy tasks that sometimes our services don't have time for. So I spend a lot of time doing reminder calls for people to have for certain bits of treatment, or using an interpreter to take a lot longer over stuff. We've got spaces in my own clinics where I could bring someone in for medication counselling. And I think as a service, we place really high value on giving time and resource to helping asylum seekers engage with their plans of care. So yeah, that's two examples, I think, of what we're learning, what we're doing.
Yeah, which is brilliant. And I was just going to say to both you and Alison Ward, who's on the call, if there's anything that you want to share about your project and your work, and you want to put it into the chat box, because I think people will be inspired and want to copy you, then please do, because this is how we all learn, is to see how other people have managed to figure out a way of making things better for their patients. Joanna, you are also an inspiration, just like Grace. But the thing that I remember when we talked about was that, I guess, the human aspect of all of this. And one of the reasons that WHAM exists is not just because we want everyone to do QI or we want people to do health equity work, but actually as solidarity for each other, because we are all working in a system that is under huge amounts of pressure. And the question that we face, every single one of us, is how do you do good in a system that is set up for you to fail? And I just wondered, as we kind of round off on you, like, what have you found to be a helpful approach for keeping yourself going, just as much as Grace had to, but then also enlisting your colleagues to help you?
Yeah, again, a few things. I think teamwork is massive. So like using each other as a sounding board and problem solving together. Also, just as a team, making sure that you debrief. So I've been in situations where we've encountered lots of traumatic stories, or really difficult situations to solve. Like when you're working with asylum seekers and refugees, you often encounter that a lot of services don't have capacity for them, and then that's really infuriating because you make your referral and it gets rejected, or they haven't heard anything, and so that can take its toll. But sharing that with your colleagues and having a space to process. So we had before, like, a team time with a psychologist, which was really valuable, and just realizing that we all felt like that makes it so much more manageable. And then the other thing I would say is that we've all learned is that you can't fix every problem, and when like advocacy often does involve going above and beyond. So it's what I'm saying isn't the opposite of that. But I think learning that you can't fix everything, and so then I think often my approach has to be, I'm going to do a really good job of what is my job, and then think about the other services that I can draw on. So a really valuable one, again, this is something that Ali has influenced in my own practice, is referring to early help as part of social care. So across the board with my patients, in respiratory and infectious diseases, I think I have quite a low threshold for putting in a referral to early help, because that is a service that has is more set up to be in the day-to-day lives of people and do more assessment. And so I think I'll maybe go above and beyond in being a bit curious, kind of like what Grace was saying in terms of asking, are you okay? So, but then doing the referral and knowing that I've done my bit, because also it's not counterproductive for us to try. It is counterproductive for us to try and solve every problem. So yeah, or like linking in with social care if they're already known, things like that. Yeah.
Brilliant. Oh gosh, thank you so much, Joanna. You are wonderful. And that was just really, really great to kind of get your perspective on things, which I think for a lot of us is slightly different, slightly to the side in some ways, but completely necessary. And I'm really, really glad that you were able to join us. I'm going to shift over to Tony now. And for many of you who are watching, you probably know Tony Waterston, because at least for me growing up, he was my inspiration when it came to things on what we call social pediatrics, which is basically this broader way of thinking about child health practice. And Tony, I'm going to ask you what might sound like a school question to start with, which is like, what's your definition of social pediatrics? But also, how do you think it might have changed since you first started on that path?
Well, I think it's become much more accepted. But I mean, there are definitions, but basically it's about the child and society and how society affects the child. And that very much is about schools, social services, income, demography, where you've come from, a whole range of things. And basically the child is at the center, but you have to understand that there are so many influences coming from these different directions that have to be taken into account. So that's how I see social pediatrics, seeing the whole child in the round and their place in society. And child rights, of course, is an extremely important part of that. And I think it's changed a lot, because when I was the first community pediatrician in Newcastle in 1989, I think it was, as a consultant. And at that time, they were very much seen as the bottom of the pile, as it were. Although, in fact, Donald Court, who was the professor before that, had started the whole concept of community pediatrics in a big way. So I think there were people who recognized it, but many of the other pediatricians didn't, because they thought, we didn't use the term social pediatrician, but countries do, and they think of that, oh, well, you're a kind of social worker then. And that wasn't seen as being a very prestigious thing. So, but that's changed, I think, really very hugely. And I think as a result of the college understanding it, in fact, David Baum, whom I respect greatly, who died on a cycle ride, he was featured actually in the last e-bulletin, died on a cycle ride raising money for Palestine and Israel healthcare. But he became the president of BACH, that's the British Association for Community Child Health, before he became the president of the college. And that was really, I think, so that he would understand what the basis of that was. And he really started a trend in the college of social pediatrics. And then he was followed by a number of other people like David Hall, who was, in fact, a community pediatrician himself. So I think it's influenced the development of the college, and then the training has done that. And I think in particular the introducing the concept of the determinants of health, which really, I remember Michael Marmot, who's the guru of this, was invited to speak at the college for 10 or 15 years ago about the concept of the social determinants of health. So I think it's my impression from young pediatricians now is that there isn't nearly such a barrier as there was between in hospital and out of hospital, and between disease and the environment that people live in. I mean, I tend to be a bit over optimistic about these things, but I do feel that it's going in the right direction.
Well, again, I think we've got a really optimistic panel today, haven't we? But what is really interesting and what's wonderful, Tony, about you is that you've got this historical perspective on pediatrics in general, but particularly this kind of movement of social pediatrics, which by no means started with you, but it definitely for this kind of later part of the 20th century, early 21st century, this is what we're talking about. Now, for young pediatricians now, I think you're right that the social determinants of health is now, common parlance. We say it all the time. We talk about it. But I guess the question is, do we do it? And by that, I mean, where has clinical practice actually been changed in any way that's meaningful for patients? Now, obviously, the work that Joanna and Ali are doing at UCLH are great examples of how practice has changed. And obviously, the way that Hannah's practiced with Grace is a wonderful example of how practice can change. And obviously, that's what we're trying to help people do with WHAM. But I wonder, you've taken all sorts of roles, right? So you're obviously a clinician, you're also an activist, you've been in the college, you worked in a more official capacity. Again, for you, which of those, or maybe a combination of those, what is it that really to you is advocacy? And what is it that you would tell young clinicians now who want to do something, but they don't necessarily believe that they should be running the college, for instance?
Well, I think it's a journey, advocacy. It starts with the patient and may continues with the patient. But then what that throws up is the fact that there are systemic problems and that you can't deal with it so easily just by a social prescription or individual care, that you have to bring in other things. And that's where, as Grace and I think Joe also said, the system is very difficult to understand for all of us. I mean, when I started relating to education and special needs and social services, I didn't know where to start. And then I met a few educational psychologists, and that was a big help to understand. You need to meet the people who are involved in these other disciplines to understand how the system works. Anyway, I think in relation to how you do it, I think the college is a big help, and I think it's the training. I see really the answer in helping this is college training, adding on toolkits, experiences, attachments, and basically helping people to get out there and meet other disciplines. And the area, the place I think that has done this best is Leeds, where they had and still do, where they had a master's in child health, which had an advocacy module set up by Mary Rudolph, who's a great pediatrician now in Israel. And she set this up really on the basis that they really had to learn this. And it taught it in a very good way. So, for example, they kept a diary of the patients they'd seen over a certain period that had a link with something social, and they also kept a diary about newspaper references to child health, and it was so revealing because it showed how many social issues there are, and how important this is in the press as well. Although the press angle is sometimes a bit superficial. So, and then they analyzed that, and then they did their own project. So I think it's through directly helping young trainees to do a project around advocacy. And I learned so much about this from the USA and the American Academy of Pediatrics, where they, despite all their political problems, they have a very, very good community pediatric system and training. And they have something called CATCH, which is the Community Access to Child Health program, which is funded. And you can get a grant. You can apply for a grant, a CATCH grant. And we ought to do this here. I raised this both with David Baum and David Hall way back, but they thought we already did it here. But what we don't do is have sources of extra funding. You can get a CATCH grant, which lasts a year or 2 years, and it enables you to do something extra and fund it in research or practice or whatever. anyway, there are a number of ways, I think, that we can approach this, but it does require definitely both the experiential contact with what's out there, and secondly, the support of the training institution to make sure that this is seen as an important part of training. And I don't think the college is quite doing enough about that yet.
Okay, well, they are moving in the right direction, and you know, I think part of also what I think you managed to do, Tony, was you were able to push the college in that direction. I think that's something that we don't often think about in terms of, we don't see ourselves as being necessarily people who are, you know, college officers, and yet we can still push the college to do the things we want them to do, right? And you know, I sometimes think of WHAM as being a little bit like that, being that annoying fly in the buzzing in the ear of the college to say health inequalities, what are you doing about it? And you know, I'm not saying that we are responsible for what they've done, but I do think that the college has moved in the last few years in terms of some of that work. And you know, that's obviously credit to Camilla Kingdon, who was president over that time. But it does take all of us to kind of push big institutions to move in the right direction. Now, I want to be able to open up questions to the floor, but before I do that, I have one thing that I want to ask you, Tony, which is that lots of the problems that we face today have their origins obviously much further upstream than the patients that come into our clinics. And I wanted to ask you what you would say to those who criticize doctors like us for being political when we actually try and advocate for our patients, whether it's Gaza, whether it's you know, refugee status and that kind of border controls and all that, or whether it's just literally resources in the NHS or austerity policies. What would you say to those people who want to criticize doctors for being political?
Well, we need to be political, but because basically this goes so long back in the history of healthcare that there have been doctors who've been political, because the determinants of health are political. Inequalities, poverty is the biggest determinant of health in the UK, and you can't tackle that without a political approach. And the same goes across the board. Asylum seekers, climate change, and so on. But it means, I think the difference from what people who criticize it is that it's not party political. So it's small p political. That means understanding the political system and how you can influence it, but not taking a line that says, oh, I'm a Labour Party, so I'm going to support the socialist approach to poverty. It's about seeing what the differences are from an academic point of view, from the evidence, and then looking to where the evidence may lead you. So, and I think it's simple when you get there. I think the college has got that to a considerable extent and is political now. I saw that in America, where the American Academy has a special department dealing with Congress. And it's doesn't support any party. They may invite members from a party, but they invite members from the other party, and they're trying to highlight the child within that system and what policy will benefit the child. So that's the line we should take. And I think there's no question that we need to be political and be overt about that, but definitely just steer clear of any alignment that's going to say, oh, you're just doing it because of your individual preference for a particular party.
Oh, that's fantastic. Thank you, Tony. That's a really emphatic call to all of us to kind of be daring when it comes to being political. And thank you again for being such an inspiration throughout my career, but particularly also in just what you've just offered in our WHAMinar. I am going to open up this now to questions, and these can come in the chat box or they can come directly from you as our audience members. If you have a question, please can you raise your hand? Or make some kind of noise in the chat box. And if not, then I've got loads more questions for people, but I think you've probably had enough of me.
We have a comment from Una in the chat box whilst we're waiting for more questions to come through. That's all right. I read it out for everybody. Would that be okay?
Go for it, Helen. Yeah.
It says, thank you all for this excellent meeting. I spent some time as a trustee for an advocacy organisation that taught me about the additional role of independent advocacy. I think that many children's health professionals believe that they are the only advocate that the family need, but I now think we should follow Joanna's advice, advocate for what we can or know about, but also seek independent advocacy for the parts we cannot reach as health workers and where parents might be less effective as the voice of the child or have different views, priorities from the child or young person.
Yeah, and that's it does come back to what I feel like was a takeaway from Joanna's section almost, which is that, you know, advocacy is a team sport, right? And in which case one of the questions is, Tony, you referred to that kind of advocacy module and masters in Leeds, but actually why are we not getting taught advocacy interprofessionally? Because there's something here about knowing each other's strengths and what we can add to some of these things. Actually, I think a lot of us are blind, not intentionally, but we don't know what other people can do on the team. And actually, I'll invite Joanna, Tony, and Grace to kind of pitch in here to this idea of like, how can we work together better, such that actually as a team we are the advocate, as opposed to just like one member being that advocate. Does anyone want to take that?
Yeah, I would make a comment, which is I think the need to be interdisciplinary aspects to our training. I mean, I was fortunate in working in Palestine that we had a diploma, then a master's, which was for doctors and nurses, and that was the first time I've been involved in that. I mean, we'd said at the beginning it needed to be multidisciplinary, and it made such a difference. And I've seen that in some of the MSCs around the country, which are Warwick, I think, had a multidisciplinary one, and some others, and it's hugely beneficial. But if you don't have that, then maybe some shorter training programs, doing the training together, postgraduate training. And for example, child rights is a really good focus for doing that, because we may get a better insight from other disciplines of how you tackle that.
That's brilliant. Did Joanna or Grace want to pitch in on that?
I would just say the value of like relationships in your team is really important. And then it's so easy just to have relationships with each other over email now, isn't it? But I think if you're actually connecting face to face, so for example, a weekly team MDT is really valuable, that kind of thing, and making space to actually talk, I think, is really valuable.
Ali, did you want to speak directly to this question?
Yeah, there's a couple of observation type things about some of the work that we've done with Respond, which is University College Hospital's integrated refugee health service. So when you're thinking about multidisciplinary team working, one of the things we've done is set up a very formal multidisciplinary team that acts almost as a virtual clinic. And we can offer advice and guidance, not just to complex cases locally, but also nationally. So thinking about formally, can you set up a team where you get experts and people with lived experience to create a virtual multidisciplinary team that people working out on the front line in the community can bring the most complicated cases to? And that means people get access to expertise that perhaps they wouldn't have access to. And when we reviewed the work of our MDT, we also learned that they did quite a lot of upskilling. So people came to meetings and went away knowing which charities were operating locally that they could refer to, beginning to understand the language that can be used in Home Office letters, etc., to support and advocate for families. So I think there's informal MDT working, but there's something also quite special about a sort of protected, clearly identified MDT that people can access to. So that almost acts as we used to talk about team around the child, and then we began to talk about teams around the team. So kind of acts as a team around the team around the families. So that's one thing to say. And then the other thing I wanted to say about advocacy is the power of data in advocacy. I think as frontline clinicians, it's the natural reaction is to feel that the stories advocate the best, and I think we will probably still continue to believe that the stories we feel advocate the best. But actually, we found when it comes to advocating at policy level, so at integrated care board level or beyond, it's the numbers and the data they want. That's what's going to make them change how they fund services and make sure that services are delivered to the people that most need them. And because of the complexities, particularly within the asylum population, but also through other inclusion health groups, conducting formal research within this population can be involved with a lot of ethical challenges. And so actually, we can't just assume that somebody clever with a massive NIHR grant somewhere is collecting the data we need to advocate for these populations. Actually, people on the front line who are changing things, who are working with vulnerable families, need to be collecting their data locally as part of service improvement projects, because that data can then be used, even if it's only small, a small amount of data, to advocate with numbers for better services. And the more of us that are in our pockets of working are collecting data, that data can be synthesized together, albeit rather crudely. And, you need the numbers. You need to be able to say, if you do it this way, this is what happens. If you do it this way, this is what happens. So just to kind of cry out to anyone and everyone who thinks, I've got a little bit of time to do some sort of QI or audit project, please dedicate that time to work in the most vulnerable and needy populations, because that's a really powerful way to do advocacy as well, I think.
Oh, that's fantastic. Thank you, Ali. Like, again, it was interesting when I spoke to Jo a few weeks ago. She clearly recognized the value of research, but said, that's not what I do. That's not what my skill set. And I think again, this whole thing about like advocacy as a team sport, and your excellent example of the virtual MDT is that everybody brings a different thing to that the big story, right? Which is individual patients, which of course, like Grace, like if you hear that story, how could you not be moved to want to change things? But you were absolutely right, Ali. When it comes down to it, we're talking about people who really just care about the bottom line, don't they? And about what's in it for them in terms of like the purse strings and all of their kind of pressures that they have when it comes to policy and government and all the rest of it. And there's something about, I think, clinicians who do have access to patients linking up with researchers who are often looking for good projects to do, but don't know what to research. They just don't know what the problems are on the ground. And I think part of us, what we have to do is link up with them, because they could do the work for us if they knew what to direct it towards. And you're absolutely right. There's nothing to stop any one of us doing the small data collection, as you described, very locally, because often that's the start of something, isn't it? That's the thing that kind of allows a ball to start rolling, and so that more investment can kind of come into a certain area. But that's fantastic. Can I just say that the virtual MDT idea is fantastic. Have you written it up yet?
For anyone that receives the British Association of Community Child Health newsletter, it's summarised in the most recent version of that. I don't have a digital link to it yet, but that's where we've written it up. And the link that Joanna shared in the chat, if you go to the UCLH web pages, one of the web pages is how you can refer into our MDT.
Brilliant, because I'm sure people will want to know more about that. Any more questions? Or did anyone else want to have a comment that they wanted to feed into this?
Can I just say that it's been really helpful to listen to everything that's been going on.
Who's speaking?
It's Evelyn. I'm a children's community nurse.
Oh, hiya.
I am literally a year into it, so I'm basically newly qualified. So it's been really lovely to kind of hear what's going on. And obviously in the community, we deal a lot with the kind of asylum seekers. We've got a lot of stuff that we have to sort out socially, or people that come over in crisis and housing. And so it's very much, it's not just nursing clinically for us.
Yes.
So yeah, it's been lovely to hear it. And I just wanted to say, I think one of the big things for me for advocacy is that it starts from within as well, from within the professionals. So there's previously been places I've worked with before that kind of, they have derogatory tones of the way they speak to people, or that's the rat house, or that's the cockroach house. And I think in doing that, you are not advocating for your patient. And I think that's so important to remember, that actually the way we phrase stuff and the way we see it can actually have a real impact. So those people weren't then doing stuff for those people. They were kind of just labeling it and making it somebody else's problem. So I'm really pleased in the place that I am now, because it's a lot more like focused on social staff and helping and advocating.
Oh, that's really nice. Thanks for pitching in, Evelyn. And I'll just say that is so important what you've said there, which is that the culture, just the basic background culture, is really pivotal here to how we signal to more junior trainees or clinicians of all stripes, about what this means, about what this work means. And you're right, like simple uses of certain words and language can tell younger clinicians what they ought to be doing. And I think, if nothing else, that's one way we can all advocate, can't we? We can all be respectful, first of all, as a very baseline for all of the populations that we serve. But I think more than that, we can also talk politically, perhaps, in like as Tony was talking, but also about like, service improvement, change, data collection, kind of bring those things into our everyday like conversations, whether it's in ward rounds or it's in MDT meetings, but kind of shift the way that we consider all of our roles such that advocacy is business as usual and not the special thing that you do if because you think it's like something you add on to your otherwise busy day. Tony, you've got your hand up.
Yes, just very briefly, just to back up on the data thing that Ali mentioned. I think this is so important. And just 2 points I'd make about that is that there are things you can do locally in collecting information, particularly from children. And I think the views of children really are very powerful and can bring about change. Like if you want to change the system where children's waiting areas or are young people being seen first before their parents or this kind of thing, then the voice of children and young people, it's not that difficult to collect that. And the other point is just about working with researchers. And my colleague, Nick Spencer, who's really done more work than anybody else in child poverty in the UK in relation to health, does research himself, but he works with other researchers who are very keen to come and really present evidence which can make a difference. So I think, and that does make a difference when you do something like that.
Is that an advert then for us all to get in touch with Nick Spencer's team if we've got ideas?
I'm sure he'd appreciate help.
Great.
We've had a question in the chat from Hannah as well, Goody.
Yeah, I think she was directing that Ali and Joanna, and Ali says it's on the way, it sounds like. Yeah, but it is a great question. This whole thing of the language that we use, obviously between ourselves in terms of cultures, but also for advocacy in our letters and our communication across sectors. And one of the things I've realized in my time was that there are certain ways to write that housing letter such that actually we can get the result like that Grace got. And so one of the things, and when you said, Ali, about the virtual MDT, but formalizing that relationship, there's something about interprofessional education that also happens as a result of that, so that you can have people from the housing sector teaching doctors what it is that needs to be written on that piece of paper, such that actually the right triggers are going off. I mean, look, if everyone remembers how they had to learn how to speak to radiologists to get that MRI that wasn't going to be given to you otherwise, you have to build a case and you have to use the right language. And there's something about doing that, but across sectors as well, whether it's education, whether it's housing, whether it's social care. Joanna, what do you want to pitch in there?
Yeah, just that a little tip is that I found the safeguarding team in our hospital to be really helpful in this regard. So I sometimes drafted an early help or a social care referral, and then they've looked at it and told me if I've rephrased it, it will have more impact. So that's quite an easy win, I think, for us in the clinical setting, that if we've got helpful safeguarding teams to help with exactly that, what you're describing.
That's brilliant. I've never thought of doing that, but that's like genius. I hope they won't mind us sending them out letters.
Goody, can I just,
relationship, isn't it? Sorry, Ali, go on.
I just wanted to say I'm so glad you brought up safeguarding, Joanna, because actually this is safeguarding in its wider sense, okay? Not child protection, we're not talking about physical abuse, etc., but we're talking about ensuring that every child who has the right to access services gets the service that they deserve and meets their potential. That's proactive safeguarding. So if you try and speak to your safeguarding team and they say, why are you contacting us with this? You say, this is safeguarding. This is taking action to make sure that children have access to the care that they're entitled to as a basic human right. So this is safeguarding. And I could talk about this ad nauseum. But
well, I might bring you back, Ali. I might bring you back on a different WHAMinar to talk about safeguarding.
Yeah, but I've sort of slightly promoted the Royal College's How to Manage Refugee Child Health in the chat. So we do a whole day course about how we can get better at promoting the health and well-being of children and people seeking asylum, and there's a section on safeguarding within that, and kind of reframing safeguarding to not be about reaction, but to be about proaction. So if you want to hear more about that, you can go to that course as well.
Okay,
yeah, sorry,
Tony, you need to rush off, don't you?
Yes, I'm sorry, but it's really been good being with you.
Oh, no, not at all. Thank you so much for your time, and thank you so much for contributing. It was brilliant.
Great pleasure.
And we probably do have to draw things to a close soon anyway, because people have lives to get back to. But are there any last questions for our panel, for Grace and Joanna, who are still with us? Any last tips that anyone might want to share with people? Okay, so if not, then I'm just going to give a very quick plug to something that WHAM is now doing. We are a bit like Tony is saying, we're doing a youth co-production project, which is about health inequalities. And we are running a creative element of this co-production project in London this summer. We are looking for clinicians to take part. It's going to be a theatre/dance/poetry project where we co-produce with young people to think about solutions to health inequalities in their area. If you're at all interested, then please can you click on that link and tell us why you're interested and why you might want to take part. Grace, your hand is up.
Yes, sir. Yeah, I wanted to add some tiptoes. Yeah, because we asylum seekers face a lot of challenges, and it is not easy. But by pulling ourselves together, we have to make and having a lot of struggle. We feel like we are down. We are just alone. No one is there for us. But there is this spirit in us that no matter what, we have to keep on fighting for our kids, fighting for them. Because if you don't fight, no one will come there to assist. You have to seek and to ask. That's the tiptoes for asylum seekers. They have to seek and ask, to be open, to say what they are going through. Because if someone keeps quiet, no one will know the problem. No one will know what they are going through, because we all face a lot of challenges as asylum seekers. So it's good for them to be open, always to look for solutions and never to keep quiet with their problems.
Yeah, that's so
and with
amazing.
and with that, they will see that their children can make it further in life. But if they did not speak, their children could be still there, not knowing where to start, not knowing what to do. But once they are open and speak up, they will get a lot of help and they will assist their kids.
Oh, that's a really lovely way to finish our WHAMinar today. And I'm sorry that we've run over a little bit, but it's absolutely worth it, I think, to hear from everybody. I just wanted to round off with what I think are some of the amazing take-home points from today's session, which is that ask, as Grace said, is everything okay? Advocacy is a team sport. You can't fix every problem. And show the data, find the data, show the data and share it, because that's how we're going to actually start making a case for better care right across the board. I just want to thank all of our panelists. Tony's obviously just disappeared, but Joanna and Grace, thank you so much for sharing your experiences, your wisdom and your tips. I'd also like to thank the members of the audience who pitched in, and otherwise just for watching. Thank you for giving up your time today to be part of this. If you'd like to join WHAM, then please do. If you'd like to ask Ali and Joanna about their work at UCLH, I'm sure they'd be delighted. And otherwise, I just want to wish you all the very best. Please stay in touch if you'd like to. And if you want to join us in South London for creative co-production, then we'd love to hear from you too. Thanks, everyone.